All right, welcome everyone. We're really excited for this breakout session on predicting pandemic PPE needs in West Virginia. I want to introduce you to our speakers today. We have Brad Price, PhD, Assistant Professor of Business Data Analytics in the Department of Management Information Systems. And we also have Katherine Kopp. She is the Data Administrator with Data Driven West Virginia. So I will let them take it from here.
Thank you, Shelby. So we'll go ahead and jump right in. Real quick, just an introduction to our program, Data Driven West Virginia. So our mission is to support the state of West Virginia in advancing its causes, communities, and corporate efforts through providing data-driven technical insights and analytic solutions. We do this in a variety of ways. We work with students. We have both a master's in business data analytics program that's been around for over 5 years now. And then we also have an undergraduate minor in business data analytics as well that's offered to students all over WVU. So they can come from a variety of majors into that minor. So we do work on projects that get students hands-on experiential learning opportunities. And then also our faculty in the program work on research projects as well as business applications. And this really, we're going to talk today about an opportunity that we had working with our state to help in terms of COVID response. And Brad and I both were pretty integral in that. We had some other team members involved as well. So spring 2020 hit about a year ago. This is what our lives all started looking like. We were working from home. We started receiving stay-at-home orders. In our state, in West Virginia, the stay-at-home order was announced March 23rd of 2020. West Virginia was one of the last states to actually have a confirmed COVID case. So, I know a lot of our audience is probably from Pennsylvania as opposed to West Virginia, even though we're just right down the road. And so some of our policies and rules that were put into place looked a little bit different than what you might have experienced. The fear factor was different in West Virginia as well, again, because we were one of the last states to get a confirmed case. There was a lot of resistance to some of the orders that were put into place. And so our governor really, put a lot of things on lockdown initially until the state had a chance to get a grasp on the situation. We started seeing national headlines along with everyone else about PPE shortages. And in West Virginia, our governor enlisted the services of the West Virginia National Guard to oversee the entire process of managing and maintaining PPE inventory levels for all the healthcare facilities across the state. The West Virginia National Guard's been involved in some other efforts that we'll talk about a little bit later on related to the COVID response. But really, this led to us receiving a call right after the stay-at-home order was put into place. Within that week, we received a call from the West Virginia National Guard, specifically Major Ryan Koss, who is also the Director of Operations for what was Mylan Pharmaceuticals and is now Viatris. So he gave us a call. We had a level of interaction with him prior to all of this, and he knew about Data Driven and the kind of services and help that we could provide in this. And he gave us a call and said, we really need to best be able to manage the PPE inventory. We need to understand the needs at the healthcare facility level. And Brad's going to talk a little bit more, but we've all seen some national models, and those really didn't do the job that we needed them to do. They needed to know the needs at the healthcare facility level, and then layered onto that, they also wanted to know what the needs were going to be for about 10,000 beds across the state at long-term care facilities. So we had a huge task ahead that lied ahead. I know I attended the earlier panel about better healthcare through advanced technologies, and it was mentioned that, we now have a lot of COVID data, but we don't necessarily know certain behaviors of patients or people utilizing healthcare. And so we really worked to create a model that took some of that information into consideration. We did have some some knowledge of how people in our state were a relatively rural state. So we had some data we were able to use to look at some trends and behaviors of our citizens, and that kind of helped us to be able to forecast at that facility level. So I'm going to turn things over to Brad now. He's going to get into a lot more details about the data we did have at our disposal and the model that we built and how all of that worked.
Appreciate that, Katherine. That's a great introduction to this problem. Now, some things you've got to understand about West Virginia is we're extremely rural. We're not like some of the other places where we do have a major city or two and rural around. We're extremely rural in almost everything we do. We have a couple of major hospitals. We have a couple of major hospital systems, but those systems aren't expansive like what you may see in a more urban state. Some of the other things is we have some different challenges here with geography and the type of people. I mean, you saw we had about 10,000 long-term care beds. We have an aging population. We have a lot of things that had to be put in consideration on when we start doing this. And this is something I preach to my students, but also kind of take to heart, especially in a situation like this. This is a quote that gets accredited to George Box, and I'd call him a famous statistician if statisticians could actually be famous. But really what it says is all models are wrong, but some models are useful. Basically what we view models as are a decision-making tool. They're not autonomous in this setting because we really had very little data. We were relying on things from outside the state to kind of inform us because we had very few confirmed cases early on. Our first confirmed case was actually out in the eastern panhandle of West Virginia. In one of the population centers out there, and it didn't really get to some of the counties until weeks in, or at least confirmed cases were there. So it's something we want to think about. It's something, just kind of keep this in mind as we go. But Katherine, if you can go ahead and go to the next slide. So this may be the model everybody recognizes. This comes from the University of Washington group, but it got another name during all of this. It was the White House model, right? This was the model that was predicting how many ventilators did someone need, how many patients would they see hospitalized, how many ICU beds. It was trying to do a lot of different things for each state and severity, and that's great. And this model turned out to be very useful for a lot of different things. But the ask we had was to go to the facility level. Now, the thing you have to understand about West Virginia is we have between 60 and 65 healthcare facilities before we even consider long-term care facilities. So one of the things we really had to come down to was say, look, this is an aggregate model over top of everything. This is a great thing for like planning for state needs and all these different things, but we need to be able to put supplies where they need to be early on. We need to make sure we're getting information to people at the facility level, because one of the things you may not realize about the state of West Virginia is to get from one side to the other, it's about 6 hours. So having something in the southern part of the state and it need to be moved out to the DC suburb, that's not quick. Okay, that's not quick. While the state may look small on a map, it's a lot of up and down around here. The other thing is people move to healthcare in different ways. People may drive by hospitals to go to a doctor. So it's something we need to consider is how do people move to rural healthcare? How do we think about these things? So it's just something. When leadership would see a model like this, the first question we would get is, well, how can we use this? And it was a hard thing to tell them because of as much press as some of these models were getting. You can't. This isn't useful for the question you're asking. This is useful for something else. Here's what it's useful for. But we developed this level of trust with the state leadership and with the National Guard. And, like Katherine mentioned, Major Kopp, but also the Adjutant General at the time, Major General Hoyer, who would talk to us through this stuff and say, what does this mean? How do we use it? So we had some real open lines of communication with state leadership on this. So if we can go to the next slide. Now, there's two big differences between what we're going to do, and I just touched on these. There's two big differences between what we did and what we continue to do. And then the other models you've seen. There have been some great models that have worked in urban areas as well, but they don't consider what actually happens in rural healthcare. And rural healthcare is something at the core of how you take care of people in West Virginia. You have to consider. You've got to think about how people are going to move. Some of the habits, some of the behaviors. It can't just be, well, here's how it moves in the population centers. We don't work like that here. All right, and that's something that's been true throughout this pandemic, and we've been able to. I don't want to say we've been able to take advantage of. in helping make decisions and helping people prepare. So the two big differences for us were we needed to account for how people travel and travel for and engage with healthcare in rural states. And then PPE usage increased for more than just confirmed COVID infected patients. You think about if you go into a hospital, you're presenting with COVID symptoms, especially on the early part, you could wait 5 to 10 days for a COVID test to be returned. So until you were actually confirmed, what were they supposed to do? Well, they had to treat you with COVID protocols. They had to use the PPE that was required, could be an N95 with a surgical mask over top of it, full gowns with tape, eye shields, goggles, all of these different things. Every hospital had different priorities and different rules for this stuff as well. There was no national standard. So everybody was just kind of, I don't want to say flying by the seat of their pants, but they were doing what they thought to be appropriate. And so when we take those things into account, when we think about what those things are, here are the three places we saw people coming from with COVID or PPE usage with regard to COVID. So the first thing we saw was infected patients. Of course, we know you have COVID. We've got to treat you with COVID protocols with PPE, right? We've got to treat you with these resources. We've got to take care of you. The other thing is these tests have false positives, especially early on with some of the tests and some of the issues we saw. False positives could be a little bit higher, right? But there's still a false positive rate on every test you take. So false positives. So it's not just infected patients. It's the false positives that can occur too. So that's people you think that test positive for COVID that actually don't have it. And the last one, and this was the big thing we saw from hospitals, is when people came in presenting with COVID, they had to treat them as they had COVID, whether they confirmed or not. You had to be treated like you had COVID. Why? You've got to protect your healthcare workers in this case. And that's what this entire project's about, was protecting healthcare workers and our first responders in these cases to make sure they had what they needed to do their job and help us to get to the other side of the pandemic. And we'd be amiss not to tell them thank you for this. Like, as we're still going through this, they're still just doing an awesome job. They're absolute rock stars in the way they've taken this on, and we're extremely grateful for them. So Katherine, let's go ahead and go to the next slide. So let's talk about modeling. Again, I'm somebody who works in ML and stats and all that fun stuff. So the model is what really got us. And I've got some training in some of the biostat and epi models from when I was at the University of Minnesota. But it's also one of those things where we're kind of having to merge the epi models with hospital operations, because we're actually seeing the real life. Not only are we modeling the disease and how it's going to get into the population, we're also modeling how hospitals have to operate at a facility level in rural West Virginia. So to say it was a tough ask would be an understatement. There were a lot of late nights. There were a lot of early mornings. There were a lot of phone calls going, does this even sound reasonable? And what we settled on was going back to some of the core epidemiological models and mixing it with those business operations concepts, those hospital ops. What patients are they actually seeing? So there's two models you may hear of when you think of epidemiological models. A basic SUR model, which is susceptible, infected, and recovered. And as you look at this, that's how people kind of move through the infection. You could get the infection, susceptible, infected, you have the infection, recovered, you're through the infection, you're fine, you have immunity, right? Great, awesome, that works. But there's also this model that's considered a CIS model, where you move from the susceptible population and you go into the infected. But then once you're infected, you can be reinfected, okay? And we kind of looked at both of these models and said, neither one of them's right for this, but a combination of the two would be. So let's go ahead and let's move to the next slide. What hospitals were actually seeing was a mix of these two, okay? So we call this a SUR model with a CIS gate. And this is what hospitals were actually seeing, how they were moving and how they had to treat PPE. So the susceptible population, right? That's everybody a hospital is responsible for. And we'll talk about that in a minute, how we calculated that, because that can be a core problem. But then we would see the infected population, okay? The people who actually had COVID, and then they would recover. All right, that's the way we were working last May. You would be susceptible, infected, recovered. But there's also that secondary population, that suspected population. You have COVID, you could have COVID, you may not have COVID, but we've got to treat you like you are. We've got to treat you like you have COVID. You know, you may throw a false positive, and that's okay. You may present with symptoms and it not be COVID, it be something else. But we at a hospital level still have to treat you like you have COVID. So you're using supplies, you're using resources that are assigned to COVID resources. All right. These are the extra things we need to take advantage, the extra things we need to make sure our healthcare workers are protected and we're protecting our population. So basically what we did here was we created a model where you move from susceptible to infected at a rate of beta and infected to gamma, or infected to recovered at a rate of gamma. And basically what we're saying is this is how you transition from one stage to the other. All right. Now, susceptible to suspected, this is where people started to have a fear factor. If you were presenting with any symptoms, you were going to the hospital. You were going to go make sure you didn't get worse, right? But what was happening was they were moving into the suspected population and then they were testing out of it. So as we move into the susceptible, from susceptible to suspected, we're moving with a parameter of rho. And we tied that to fear, right? How the infection rates were actually moving in these areas and in these regions really had a play on that. It really mattered. But then as you would test out of it, as you would go from suspected to, hey, you tested negative here, you're back in the susceptible population. So mu is this dynamic parameter. It depends on how long it takes you to test in or test out. So we're looking at these different things. That's what we had to consider. So this is the model we put forward to the National Guard and to the state to use. All right, now let's go ahead and go to the next slide. So where's the data coming from? How did we get this information? Well, we get a daily survey from the West Virginia Healthcare Association on facility level information. So it's how many patients do you have? How many are confirmed? How many are susceptible? Or how many are infected? Or how many are suspected? I'm sorry. So we have suspected, confirmed, and then we have all the information on, are you in the ICU? Are you not? How many beds do you have available? All these different things. All right. So we're getting that directly from the hospitals themselves every day through a third party that helps manage them. Now, how do we know the susceptible population at each facility? This was the first thing we had to go out and look at, and we've confirmed it. We had access to county level admission data to emergency departments. And in West Virginia, how people move, they'll drive past another hospital to go to a specific ER because they think they'll get better care. So it means somebody could be driving 4 counties. All right. It means somebody could be moving. And what we found was that people in this case actually move like they're moving to the emergency departments. That was an assumption at the beginning of this thing. And it's something we've confirmed since. We're working on a couple papers to show this actually. We have regional market share information for every facility in West Virginia. All right. So because we know how people are moving, right, how people move from county to hospital, we're able to kind of go in and say, okay, this is the percentage we see from each county. We have a regional market share to say, look, this hospital is now responsible for this percentage of this region. All right. We're able to cross-reference this with census population data that's available to come up with a number for every hospital in the state saying, given the 1.8 million people who live in West Virginia, this hospital is responsible, or they're not claiming responsibility, but based on people's behaviors, they are responsible for this many people. That's the susceptible population associated with each hospital now. We're able to get daily doubling rates and track these RT values actually through the West Virginia National Guard and through the West Virginia Clinical and Translational Science Institute that keep these numbers up. So it allowed us to understand how the infection rate moved based on everything that was happening, whether it be, quote unquote lockdowns, or how the social distancing came into play in the state, all of these things. Because in West Virginia, in a lot of areas, we live socially distant, right? We live socially distant. So it's something you've got to think about. So the doubling rates came into play. So what we had at this point was everything we needed to use this model. All right. And we continue to use this model. So let's go ahead and go to the next one. The rates were calculated from each county department of health and aggregated over the footprint of the EMS region. So again, we're using emergency medicine practices, especially in rural areas, to kind of say, here's what's happening. So the rates and the numbers we get are calculated over a footprint in a region to kind of get regional, quote unquote, doubling rates or regional RT values, right? Hospitalizations are calculated as a rate of historic infections relative to the hospital footprint. Basically, all that we're saying there and all that means is we know not everybody who's infected is going to go to the hospital. What we do is then we back calculate. We calculate them. We just use the basic math of what percentage of people who we have an infection on actually went to the hospital and were admitted. So what we're able to do is we're able to give this rate of like, hey, we're seeing this level of hospitalization based on infection. All right. And that's something that really helped kind of plan and kind of take it from the, okay, here's the epidemiological concept to the model itself. And then there's a ton of local information in this model. It mixes epi models and business concepts. And that's one of the major differences and one of the keys we were able to utilize. So let's go ahead and go to the next slide. From the Hospital Association, we also get a PPE survey. It's coming 3 times a week right now. There are questions of how much is on hand, how much do you have in N95s, gowns, surgical masks, gloves, or eye protection, right? And how long do you think it's going to last you? Because we want to use the subject matter experts on the ground. We want them telling us. So the survey goes out, they send it back. We're very confident the same people have been filling out the survey since the beginning of this, because we've watched the data quality, we've kept an eye on it. But it's also the data evolved with national priorities. You know, early on, we were the ones who designed the survey, and we wanted a day, like your best guess. And we know it's not right, but your best guess on how many days is this going to last. Then the federal government started becoming very interested in the PPE problem. So they gave them bins. So will it last 0 to 3 days, 3 to 7, 7 to 14, 14 to 21, or longer than 21 days? We had it at the original. So our models have evolved to account for this data. And it was something we found very interesting about this project, I'll say, is that we'd have a model, it was doing great, and then all of a sudden the data would change on us and we couldn't get it back. So we'd have to update the model, we'd have to use the new data, we'd have to do all of these things. And it's not the data from like a model drift perspective from machine learning. It's from the, like, we go from an actual number to now a bin. And we'd have to learn to adjust with that and kind of think about what it means. Now it's just some math. At a facility level, we're able to forecast the number of patients coming in. We get facility level PPE usage. How many patients or how many things are you using every day? Or how much do you have on hand? How long do you think it'll last? Here's how many patients you have. So all we need is little multiplication. PPE usage per patient, which we call a burn rate, times the number of patients forecasted. And what we did was we supplied this for every hospital in the state for 100 days. And we continue to do it. Every Thursday, the forecasts go out, and it's for 100 days moving forward. Go ahead and go to the next slide. So we've monitored and successfully maintained the supply. The way the National Guard is set up, they've created a backstop for the state of West Virginia. The one thing, and it's, you know, good, bad, or in between, in the state of West Virginia, you know nobody's coming to save you. You know you're not high on the national priority list. So you better figure it out yourself. And we've gotten pretty good at that since, you know, since the inception of the state, I think. But it was really kind of here in this. We had that backstop. That backstop has led to us not having any PPE shortages, even when hospital supply gets really low. We're still forecasting out for the next 100 days. We're taking in some of the military emergency management principles where there's times where we have to use worst case scenarios. There's times where we have to think about it. You know, one of the things is long-term care facilities. Long-term care facilities, if you have an outbreak, basically the entire facility is now treated with COVID protocols. So you go from 0 to 100% like that. So the thought is, how do you deal with those? How do you take those? So at one point we were forecasting somewhere close to what happens if half the long-term care facilities in the state go under COVID protocols, because we had to be able to back that up. Again, West Virginia has an aging population. We know how this disease would kind of impact those people. And we've seen it, especially with new initiatives like Save Our Wisdom that came out in our vaccine rollout, where we targeted long-term care facilities first with vaccines. So yeah, we've been able to kind of set a good backstop for the state and set up some protocols. Currently, we're working on a playbook for hospitals in rural areas for what should you do the next time a pandemic hits? What should you be expecting? So if we go to the next slide. Things we learned. There's not a national COVID-19 models are not one size fits all. They won't work for every problem. The one thing you can see is PPE usage greatly varies among facilities. So I've got 2 plots here. The one on the left is surgical masks. The one on the right is N95s. And these are for 2 groups of hospitals, completely de-identified. but basically these are what they have on hand every week. And you see some different, or you see some different trends here, especially relative to time. So it's something to think about here. And then the other thing we've learned, and the thing we've kind of held on to, is large scale problems can be solved through collaborative partnerships. This public, we're a public university, but we're not working directly with the government. This public relationship we had, is what I'll call it, are things that really take on. So Katherine, I'll hand it back to you, and you can wrap us up here.
So yeah, we've just got a couple minutes since the previous session ran over, but real quick here, speaking of collaborative partnerships, so we've actually continued our work. Again, the governor's been using the West Virginia National Guard to also help with vaccine distribution through the Joint Interagency Task Force that he assembled. And Brad and I, with Data Driven, we've actually been, over the past 2 months, we kind of switched gears a bit from the PPE predictions and forecasts to building out an entire vaccine inventory management system for them. So we worked using specifically our studio. We used our Shiny. And so you can learn more about that. There'll be some more press coming out. And then I know, because we're short on time, you're welcome to email us any questions that you have. And thank you all for your time today.
So I just saw a question from Justin.
Yeah, I was going to say we have a question in the chat if you guys want to answer that.
Yeah, so Justin's asking, can you give us an idea of what kind of staff you're all working with? Students, professors, and industry professionals. So I'll let Katherine speak more, but for this project specifically, it was Katherine, myself, our colleague Darianne Drake, Madison Verbosky, who was Katherine's GA at the time, did some work on this as well. We had a couple students working from the National Guard side because we spun up the entire National Guard in the state of West Virginia. So I had 2-3 students working from the National Guard side on this, not from our side, helping run down data. One of the things I will say is the National Guard in West Virginia is just so amazing. They're extremely talented, and they're here to help our state. So they're a huge resource. We had some other professors who we bounced ideas off of. The ones that come to mind right off the top of my head are Jane Rosinski, Dan Grossman from our econ department, who talked me through some rural healthcare stuff, John Saldana from our global supply chain management, and then one of our colleagues on a few papers, Doug Thomas from University of Virginia.
Yeah, just to add to that, on the student side with the National Guard, we had two members specifically. One was an econ major in our business data analytics minor. So he was boots on the grounds, literally. And then we also had a supply chain student there as well that worked on this on their side of things. So that was really helpful. And now moving forward, we've automated a lot of the process, but we do weekly forecasts every Thursday. So my current graduate assistant, Ryan Midkiff, he does that this week. But our projects range. I mean, we have several students. Usually when we work on client-sponsored projects, we usually have teams of 4 to 6 students, and we'll have a staff member as well as a faculty mentor on those projects. But we always scope projects in advance to kind of determine what resources we need and have available and work from there. But these, more urgent, we are a land grant university, so the prosperity of our citizens and state are really important. So these projects definitely have taken priority in the past year. And making sure that we kind of get up and running pretty quickly and pull whatever resources in that we can.
Awesome. Well, I don't think there are any other questions in the chat right now. Thank you so much for offering your contact information in case there are others, especially for those watching this recording. But especially thank you both Katherine and Brad for your time today. This was an extremely interesting talk, a super important topic. And for those that are watching right now, please feel free to check out the different technology showcases. There's a few different Zoom rooms for those, as well as a networking room so you can interact with other attendees. So thank you so much.
Thank you all.
Thank you. We appreciate it.